bells you can. All right? So in 10 seconds, we're going to get going. Remember, a sturdy chair, a towel, and if you don't have a towel, it's okay. Just do the motions in 10 seconds. 5, 4, 3, 2, and 1. First of all, I would like to welcome everybody to the Emory Alzheimer's Disease Research Center, and this is the fitness component. Y'all ready? Here we go. All right. We're gonna roll arms straight, feet wide, back straight, and I just want you to just rock. We get those side obliques. We're stretching that lower back, that upper back, those lats, shoulders, and hold. Pull with your bottom arm. Good. Other side, arm straight, pull with your bottom arm. Good. All right. Arm straight, back. And when I go, my chin goes down. You know, chin goes down, chin goes down, and up. Good. Now, hands together, and I just want you to just keep pulling. We contracting them shoulders, the outer chest. There we go. Creating vibration, and good. I want an angle. You ready? And go. Arms straight. Pull with both arms. Good. Other side. Woo. I'm working. Ready and go. Good. I'm gonna put it round my back. I'm gonna grab my chest up, elbows to the side, and twist. There we go. The towel is nothing but keeping you consistent with great form and great posture. There we go. Keep it going. And good. Bring it back around in front. I want you at an angle. Wait a moment. At an angle and to the top. Keep it going. Let me get the music back started. Keep going. There we go. And stop. Good. Elbows up. And I want you to go down at an angle. 5. Ready, go. 1, 2, 3, 4, and 5. Elbows straight. And go. 1, 2, 3, 4, 5. At an angle, drop your elbows and go. 1, 2, 3, 4, 5. Over top and go. 1, 2, 3, 4, and 5. Good. Great job. Towel down. Now we're about to get this cardio in. Y'all ready? Let's go. Okay. I want the abs today. Real technical today. Y'all ready? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Good. Now we're going to get the side oblique. Same leg. And go. 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. Your right leg straight, lean back, and 5 reps. 1, 2, 3, 4, and 5. Other leg, ready, and go. 1, 2, 3, 4, and 5. We're really getting those lower and mid abs. Now, I call it rocking. We're gonna rock. Come on, I want a lot of abs today. A lot of abs today. Come on, let's go. 2, come on, 3, 4, and 5. Okay. Right leg wide, and I'm gonna cross it. That's my motion, so I can really engage those abs. Ready? And 5. Go. 1, 2, 3, 4, and 5. Other leg, keep this one straight, this one at an angle, and cross. Ready? And go. 1, 2, 3, 4, and 5. Great job. Now I want you to just lean back, and I just, come on. Come on. We're just doing chair sit-ups. Come on. Keep going. Come on. Watch this. 1, 2, back. 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 Great job. All right. 10 more seconds. Here we go. I'm staying on those abs today. Next week, we really gonna turn the cardio up. But I want good details in the core today. Let's go. Come on. We're engaged, legs wide. Watch it. Big chest. Other way. Come on. I'm almost finished with y'all. I'm almost finished. Great job. Here we go. Hands here. And we getting all weights today. Come on. Rest. Arms out in front and twist. Great job. Elbows in front and turn. Make sure your back is straight now. Don't hump over. Come on. Great job. Legs closed, arms straight, and let's go reach, 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 reach. Great job. Here's our finale. Y'all ready? Legs straight and hold. 10, 9, 8, 7, come on. 6, 5, 4, 3, 2, and 1. Great job today. We worked on a lot of details, stayed on that core, great exercises for the core in that chair. If you have any lower back problems, you can do all your work in that chair to work that core. I want to say to y'all, I'm John Lewis, and see you later, bye.
All right. Did you know that you just got in like a 9-minute and 30-second full body workout? So thank you, John. Your energy is contagious. We appreciate you every week for getting our hearts going. I want everyone to go and grab a notebook and a pen. If this is your first time joining us, we try to cover a lot of information in a short amount of time. So you're going to hear from several of our experts today. Dr. Monica Parker, who is our Minority Engagement Corps Director with the Goizetta Alzheimer's Disease Research Center, is just going to kick us off with telling a little bit about our research mission, and then we will transition to Dr. Kandiah, then Dr. Bert Anderson. And after Dr. Anderson, we will hear from Whit Morgan, who will talk about our healthy aging study. And then, as you know, since the beginning of the year, we have been having the Cognitive Empowerment Program immediately following our 2 o'clock session. So they will be posting a link if you want to join them for another session for 1 hour at 3 p.m. You can. It's via Zoom. Thank you so much again for being here with us every week. We try to keep you engaged and informed while we're having to remain safe and at home until we can resume those in-person activities. This is our best mechanism right now for engaging you. So thank you. And with that, Dr. Parker, welcome.
Good afternoon, everybody. Thank you for tuning in, all 178 of us. One of the reasons, as Mrs. Dorbin has alluded to, is we need to keep in touch with you. Not so much because we just want to give you some information all the time, but we want to make sure that you are aware of every opportunity there is to maintain your health, your wellness, and keep your brain fit. But more importantly, if you think there is something awry in terms of how your brain is working, we're here to try to help give you some resources that you can access such that you can get an evaluation. Alzheimer's research here at the Goizueta Alzheimer's Disease Research Center is important because we're one of nearly 30 Alzheimer's disease research centers that are funded by the National Institutes of Health. So here in Georgia, we are kind of like your center for brain health. So we talk about everything we can do to help keep your brain fit. Now, if you are able to log into this BrainTalk Live every week, chances are your brain is working pretty well. But for many of us who are attending, we have a family member who may be showing signs or symptoms of brain dysfunction. Maybe you are aware of somebody who has a neurologic condition and you'd like to know more information about it. So for those of us who are healthy and want to stay healthy, take advantage of all the information you get from us to stay healthy. Here at the Alzheimer's Disease Research Center, we study healthy aging, i.e. we study those factors that keep people physically and cognitively functional for as long as they need to be, okay? When we start thinking about Alzheimer's and other dementias, we need to appreciate that Alzheimer's and other dementias don't just happen. They've been in process for at least 20 years. So research now is focused on what we can do to keep Alzheimer's and other dementias from taking hold, okay? Yes, there are some medications that are in development that are going to be what we call disease modifying therapies, i.e. like cancer drugs. If we give you this medication, this will stop the process of Alzheimer's or even reverse it. Unfortunately, at this point in time, we do not yet have a drug or a disease modifying therapy that can reverse the effects of Alzheimer's or any other neurodegenerative disorder, whether that's Parkinson's, ALS, or anything else. We do not have a definitive cure. That's why we participate in research. Now, one of the things that I am, if you can say you're grateful for the pandemic for, it has shown a light on how important evidence-based medicine and how important research is to getting us the right treatments for different things. You've heard about people who participated in vaccine trials. You've learned about what side effects they've learned that may be a result of being treated for COVID. You've learned that there are different strains of coronavirus that may or may not be may or may not have an effect on the vaccine. Current vaccine may or may not have an effect on those different strains. We need research. We need research participants to help us understand what works and what doesn't. So here at the Goizueta Alzheimer's Disease Research Center, we look at Alzheimer's as a life course disease, which means that you have to start working on dementia prevention, not at 60, 70, or 80, but how about 6 months, 6 years old, things like that. Grandparents need to start investing in things that help children's minds develop well, music lessons, language lessons, any of those sorts of things. So again, we look at Alzheimer's and related dementias, Alzheimer's in particular, as a life course disease. It's not one point in time where things are happening. So we have studies here at the Goizueta Alzheimer's Disease Research Center that are dependent on healthy people. We need to understand healthy before we understand unhealthy. So we will do brain images, brain MRIs. The newest technique for definitively diagnosing Alzheimer's is something called a PET scan. It's not widely available for commercial use, which means you can't go see your regular doctor or neurologist and get a PET scan. You can get a PET scan through research participation. In the course of doing the research on Alzheimer's disease, we will ask you for blood. We will check your genes because we do know that Alzheimer's is associated with genetics. And that can be done by getting a swab, maybe a blood smear, and cerebrospinal fluid. That's for which you need a lumbar puncture. People are like, well, I want to participate in research, but I don't want to get a lumbar puncture. Well, you need to look at those studies. And when they're presented to you, if you know that you don't want to get a lumbar puncture, then that's not the study for you. We have a number of things that you can participate in. Some things you can't participate in. Drug trials are generally not something for people to participate in who have not received a diagnosis of Alzheimer's. Okay, by the same token, everybody who has dementia doesn't have Alzheimer's, and a lot of the therapeutic trials are not appropriate for them. With that, I want to make sure that you're aware of what our website is so you can look at the different studies that we're looking at. But please keep in mind that a lot of research is not necessarily Frankenstein or guinea pig science. A lot of time we are doing observations. We're looking at what makes people healthy, what may make people sick, and that may be just completing a questionnaire. So if there's an opportunity for you to participate in some research study, we basically try to introduce you to any of the investigators. And if there are studies that you're interested in, please call the coordinators and enroll. Because of the pandemic, most of our studies have been put on hold. So we're not doing a lot of face-to-face things where you have to come in and talk to people. A lot of the processes, like the consent processes, a lot of questionnaires and other things can be done online if possible. When we're able to meet face-to-face, we'll get you scheduled for an MRI, maybe get some blood drawn and other things. But in any event, I want you to stay engaged, learn about the different studies, the different investigators that we have here, and enroll in something simple. Emory Healthy Aging is simple. You can do that online from wherever it is you are. And we'll have other people talking about that study as we go along. But in an event, please enroll, please stay tuned. Please keep attuned to what it is that keeps you healthy. Thank you.
Thank you, Dr. Parker. So last week, Dr. Hepburn, we are picking up from where we left off and wanted to bring on an expert who could address the flurry of questions we got last week. You want to sort of help us transition to our next topic with Dr. Kandiah?
Well, I think what we talked about a lot last week was around, we at least raised the question of reluctance to be vaccinated, why people might feel reluctant, and what assurances they might have. And I believe that was the basic point of our conversation. And I think, but I was sort of speaking in a non-expert but experiential framework, having had the vaccine relatively early on in the trial, and attesting to the benign effects on me and my wife, but also saying that the science has developed, the science of vaccine creation has developed so much in the last 20 years that the fact that with a large infusion of support, that is to say money, it is quite feasible to create a vaccine, an effective, obviously very effective vaccine in a short period of time. And so the short span of development ought not be a constraint to people's thinking, well, maybe I should or shouldn't get the vaccine. So that was sort of the basic conversation we had last week. And it's always good to have somebody who really knows what she's talking about to address this issue.
Okay, so thank you so much again for being here with us, Dr. Kandiah. Are you Is your connection okay?
I'm so sorry. I don't know why, but my computer just kind of died on me. So now I'm on my phone. So I apologize. I don't know what just happened, that I lost connection. I apologize for that. But thank you for having me. I'm really looking forward to talking to you guys about vaccines today. And I'm sorry I missed a little bit of that introduction. I didn't know if there was any specific questions that we could start with.
So the one I think that you might want to particularly address is is it safe to trust a vaccine that was developed in such a short span of time?
Yeah, so that's a great question. I think a very important one, obviously. So the answer is yes. And yes, in the sense that the processes that took place, that normally would take place, often will go in stepwise fashion. You start with animal studies, and then you move on to safety studies with human volunteers, and then you move on to phase 3 trials, which are more treatment trials. And with this, normally you wait for one phase to end, you wait for the data to get completely analyzed, then you move on to the next phase. What they did this time is that they actually overlapped some of that. So once they got the data, they went ahead and started the next phase sooner. And then once they found that it was safe, they found that it was efficacious, then they had moved on to the phase 3 clinical trials. And at that point, normally before drug companies start to manufacture vaccines, they'll wait for those phase 3 trials to go on. But the data from the safety and the efficacy, which was phase 1 and phase 2, was so good that they said, you know what, we're just going to start. And if something were to happen and we find some sort of problems with the phase 3 clinical trial, then we'll stop manufacturing. So we started manufacturing close to the same time that we started with our phase 3. So there weren't any corners cut at any point during this process. We just expedited each section along the way. So it's not like we used less volunteers that we normally would. That's not the case. I also want to just say that there are very strict ethical guidelines around clinical trials, whether it be a drug or a vaccine. And, there's multiple bodies that are regulatory that will do a lot of data safety monitoring and make sure that there's no adverse events that could be harmful to the public. So again, I just want to reassure everyone that there were no corners cut at the time of this, during this clinical trial.
So let me pose my current favorite fake news fact, and that is that Hank Aaron died of the COVID vaccine.
Yeah, so I don't think that we were ever able to say that Hank Aaron necessarily died of the COVID vaccine. Yes, he did pass away, which was extremely unfortunate, but whether or not it's attributable to that is hard to know. In the clinical trials, there were actually 14, I think it was 14 deaths, but they were not in the vaccine group, they were in the placebo group. So, as more information is sort of coming, the information we want to look at is whether you can attribute a death to the vaccine. So for example, if someone were to have a heart attack and die from 2 weeks after receiving the vaccine, can you necessarily attribute it to the vaccine? And I don't think that's the case. And, in the over 2 million, I want to just say that over the 2 million doses that have been given in the United States and all over the world, there have been 0 deaths from the COVID vaccine.
What's the typical reaction to the first or second shot?
So I think it's variable depending on your immune system. Usually most people will react to the second shot more than the first shot. The first shot tends to give you mainly just some sore arm pain. The second shot tends to make you feel sort of flu-y, and I sort of flu-like symptoms. And they come on within 24 hours of the vaccine, and they're usually gone within 48 hours of the vaccine. So very short-lived. And, Tylenol and ibuprofen can help during that time to help manage some of those symptoms.
I think when you were off, I said that my wife and I had been in the trial, and that was exactly our experience after the second shot. Maybe 20 hours of flu-like symptoms.
Yeah, and I think I also had a similar situation. And I think I got it at 5 o'clock on a Saturday, and by Sunday at 5 o'clock, I was like, I'm done. And I went to sleep, and I didn't get up until the morning. And by the morning, I felt like I was back to myself again.
What's your sense of why people may have doubts? What do you think are the main reasons?
Well, I think there's a lot of misinformation going around. And I think it's really important that when people, get information about the vaccines, that they go to the right sources. Prior to vaccine rollout, there's already some concerns and doubts about, big pharmaceutical companies, it being about money and things like that. But I think what's different about this is that, no one's making any money off of this, as far as, it's being paid for by the government for the people. So, your insurance company is not getting charged for the vaccine. So I think there's, doubts from that end. And then on the other end, of course, it's again, that question of it being rolled out so fast. And also we haven't, normally we would follow vaccine efficacy out to about 2 to 3 years after receiving the vaccine. But with this, we rolled it out quick. We don't know what the long-term, benefits are. Do we know if we're going to, need a booster in the future? There is some unknown. And I think we have to acknowledge it and not say, oh, it'll be fine. But given that there's, mutated variants now, in addition to the fact that we don't know long-term whether this is going to be as efficacious as we'd like it to, I think that puts some doubts in people's head.
There's some really interesting questions in the chat. The person said that he or she received the first dose of Moderna last week, but very afraid or uncomfortable about getting the second dose. Do you have any thoughts, any words of wisdom?
Well, I would be curious to know as to what makes him or her uncomfortable. Was it a bad experience getting the first vaccine? Some people do have side effects after the first vaccine, and they worry that maybe the second vaccine will give them worse side effects. But as far as I know, that has not been the case. But the CDC, through the VSafe app, is actually actively monitoring these. So I think there's more information to come. But it doesn't necessarily mean that if you didn't feel great after the first vaccine, that you're going to have a much worse reaction after the second. It just depends on your host immune system.
Is there any information about persons who are living with Alzheimer's or other dementias and the any possible effects on them of the vaccine?
No, but I anticipate that data is going to come out soon, because, as you know, we've actually vaccinated a large number of our long-term care facility patients who may or may not have Alzheimer's.
Yeah.
So I think that information should be released relatively soon.
I think there are questions about specific, if you will, brands. A couple of people have asked about the Johnson & Johnson vaccine. Is there anything about that versus?
Yeah, so I think the advantage of obviously the Johnson & Johnson vaccine is that it's one shot as opposed to two. The other vaccines, the Pfizer and the Moderna vaccine, are obviously 2 shots, 3 to 4 weeks apart. And everyone's very concerned about the efficacy being in the 80s for Johnson & Johnson. But I want you to sort of understand that when we do vaccine trials, the efficacy that we generally will look for is actually 60%. So it still did quite well with regards to the endpoint of around 60%. The more important thing is that when we talk about vaccine efficacy, I think there's this idea that there's an absolute, you cannot get the disease, therefore, you're safe from the disease. And I think it's really important that we also say that, even, for example, the flu vaccine, even if you do get the flu and you get breakthrough with the flu vaccine, the disease severity tends to be less. And it's the same that is seen with the Johnson & Johnson and the other 2 vaccines, is that even if you were to break through, you're that 5% of the Moderna or Pfizer who get the disease. It has found that we're able to prevent severe disease and prevent hospitalization, more importantly, and potentially long-term adverse outcomes related to the disease.
I think that's so important.
Yeah, very important.
What's your take on the variants that are coming? I mean, especially the South African, which seems to be more transmissible, maybe more virulent, and how does that stack up with the vaccines?
So I don't think that there's data yet from Pfizer or Moderna on the South African vaccines yet in detail. We know that the Johnson & Johnson has decreased efficacy against the strain. But again, I do want to re-emphasize that even if that's the case, we still may be able to benefit from a Johnson & Johnson vaccine due to the decrease in the incidence of severe disease and hospitalization. So I think there's more to come, and we will likely need a booster probably in the future if the Pfizer and Moderna don't pan out to be as efficacious as we'd like them to be. But in the same token, that's the beauty of this technology. Like, we are able to do that very quickly and, try to get, pandemic spread and control, pandemic spread under control.
Other panelists have any other questions?
This is Dr. Parker. I'm looking at some of the questions, and one of the basic things that I think people need to appreciate about vaccines or any kind of injectable medication is that there is likely to be some kind of effect, whether it's pain at the site of injection, maybe you run a low-grade temperature or fever. If you're a grandparent or a parent and you've taken your child for an immunization, same things apply. I don't think that in this environment, and I do appreciate a lot of the concerns that are here, and we don't know all of the answers, but what we do know is research thus far has shown that the COVID vaccines that have been developed have been effective, not so much in keeping you from ever getting a COVID infection, but making it less likely that you end up in a hospital or that you die from having the infection. So getting your first and second shot, if you're on Pfizer or Moderna, or getting a single shot, doesn't necessarily guarantee that you won't get COVID. What we're hoping, and the reason it's so important to get the vaccine, is that we are making it less likely that people will suffer the long-term consequences of having had this infection, reduce the opportunity for you to have to be hospitalized or require hospitalization to recover from the disease, and more importantly, to die from it if you're a vulnerable person. So the vaccine is not a cure-all, it's not the answer for everything, but it's making it less likely that some of the untoward outcomes are not something that you would suffer if you do become infected.
I want to just add to that the mRNA technology, which one of the advantages of using that technology is that it can be created quickly. And for those of you who are not familiar with that technology, rather than actually, taking a piece of the virus and injecting it into your body for your immune system to react to it, what it basically does is it injects the recipe book or the instruction booklet for you to make the spike protein, which is what the vaccine actually what the vaccine acts against. And it never enters your nucleus. There's no DNA involved. And so everything is done in the cell. And then the instruction booklet, the mRNA instruction booklet, actually just breaks down through biodegradable processes. And then your cell has created that protein, which is necessary for the immune system to react against. And the technology itself is not new technology. It's actually been around since the 80s, and there have been clinical trials. It's been used in cancer. It's been used in HIV. There was a 3-year trial with this technology for rabies. So as scary as it is that, oh, this is new technology, this new vaccine, the technology itself is actually not new. And we do at least have 3-year data on adverse events in other trials and other settings. Is it COVID? No. But we do know that we have some experience, I guess is what I'm trying to emphasize.
And 2 more questions before we have about 3 minutes. Can you address, so if people have been vaccinated, are they now, what is their susceptibility? Can they now go out and be free and roam about? And then what do we say to individuals who are getting their vaccination, but then people are telling them that's a no-no and sending them videos and just horror stories and things? How do we normalize vaccination in this current state?
So I think for your first question, as far as does it mean you're free to roam about? No, the answer is no, because what we still have not established is whether or not you can still get the disease and be asymptomatic with the vaccine and potentially still spread it, which is why we still encourage mask wearing and social distancing. Because if you got the vaccine and you didn't get sick, but your neighbor who didn't ever actually get the vaccine, you're around them, there is a potential, and we don't know what that potential is, of potential of passing it on through there. And as for your second question about all the information that's out there, I think the most important people that you should be asking are the people who are scientists, who know the science, who understand the processes, and the CDC, the Centers for Disease Control. There's a wealth of information on there. The frequently asked questions section of the CDC website is fantastic for answering a lot of questions that some of which have been posed here. So I would encourage you to just make sure that you're relying on sources that are based in science, and I think sometimes there's an emotional component to vaccines, because it's scary, and you hear, well, when I got the vaccine, I was so sick and I was out for a week, and like I couldn't, I had a big headache, or I had, my body ached, or whatever it is those symptoms are. Everybody is going to react differently. I would say over 90% of the patients had people who were in the trials. The main side effects were actually fatigue, a low-grade fever, and arm pain, and that all resolved usually within 24 to 48 hours. So that is, at least it gives you something to expect, because that seemed like it was a large percentage of the patients who got the vaccine.
Okay, any last questions or comments? Thank you so much, Dr. Kandiah. If your schedule permits, we would love to invite you to come back on in 2 weeks, because this is evolving, and things are unfolding by the day. And so we want to keep people informed.
Well, I certainly appreciate you having me on the panel. And, if there's any other questions, feel free to reach out.
Thank you so much.
Thanks very much.
And apologies for the connection dysfunction. It seemed to be perfect timing.
Well, your sound and lighting looks great. So
thank you.
All right. Okay. Well, Dr. Anderson, welcome. Dr. Anderson is on with us today.
Hi, everyone. Can you hear me?
Yes.
Okay, great. I sent some slides over. Is there any way to
Yes.
upload them?
Yeah, give me just a sec. If you want to introduce your topic while I transition to your slides.
Okay. Hey, everyone. This is Bert Anderson. I am from the Division of Infectious Diseases at Emory. You appear to have a little bit of an ID theme going today, so I'm going to stay with that theme. And I'm basically going to be talking about a research study that we have going on, looking at a novel cognitive assessment device, and would definitely echo what Dr. Kandiah said about the COVID vaccine. We really need to get more people vaccinated so we slow things down with this pandemic. So I have no disclosures today to report. So going to the next slide. All right. And a lot of folks in the audience, I'm sure, are familiar with this topic. HIV-associated dementia has declined significantly in the era of effective combination antiretroviral therapy. However, cognitive impairment is still very common in people with HIV. The good news is that for the most part, people don't get demented, but they can get more frequently some minor cognitive issues. So there's an umbrella term that we use now called HIV-associated neurocognitive disorders. That includes dementia, minor cognitive disorder, asymptomatic neurocognitive impairment. And depending on the study, that's present in approximately 25 to 40% of people with HIV who are on medications. We know that people off medications can experience these issues very commonly, but even people on medications that are working well to suppress their virus are at risk for getting this complication. So it's something that we need to understand more.
Okay, give me just a sec. I see. All right, there we go.
All right. Should I be controlling these, or I guess it's probably easier if you control them, Dr. Harper. So click to start the remote control of the shared screen. Okay, maybe I'm controlling it now. All right. So even on antiretrovirals, people with HIV who have cognitive problems are at risk for multiple adverse clinical outcomes. So those include decreased quality of life. Also, people with abnormal cognition can have issues with medication adherence. And that's really important because if people are not adherent to their medication, their virus can come back and people can lose control of the virus. And there's also some evidence that having cognitive impairment increases mortality or is associated with increased mortality in people with HIV despite being on antiretroviral therapy. Okay. So in terms of diagnosis of what we call a hand, it is challenging for most clinics to make the diagnosis of hand. Just like in some of the neurodegenerative diseases in HIV negative people, we need neuropsychological testing. And to meet the criteria of hand, you have to test at least 5 domains with at least 2 tests per domain. So I know I'm probably preaching to the choir here on that. And so most HIV clinics don't have those kinds of resources. They don't have the ability to do comprehensive neuropsych testing. So even in the best of situations, that's very time intensive, but for a lot of HIV clinics, it's basically not feasible at all. So we need more rapid tests that are easily administered and that are accurate to diagnose hand. The study that we're doing is related to a novel cognitive device, called the DETECT device. And that's an acronym that stands for Display Enhanced Testing for Cognitive Impairment and Traumatic Brain Injury. So this was a technology that was developed in conjunction between Emory and Georgia Tech, and has actually been studied in HIV negative people. Maybe even some folks on the call were involved with the early studies looking at cognitive impairment in older adults. It's been studied a lot in sports related head trauma. And a few years ago, we did a study in HIV that I'll go over. And now we're doing a larger study with HIV, but that also includes HIV negative people with amnestic MCI. So those are the folks that we need your help with in terms of the folks at the Brain Health Center and the Alzheimer's Center. To go over the device a little bit, the picture on the right, top right, is an early version of the device. It was pretty bulky. People wore it kind of like a helmet. As you can see, this is a football player who basically they were testing, and that's actually one of the groups that that people, not necessarily my group, but other people, maybe more so your group, interested in looking at this device to measure cognition in football players and other sports. So the device has been refined though. So now it is shown on the left-hand side, the bottom left, where it's now in a state where you can actually download it onto a smartphone as an app. And then you can use it in a virtual reality headset. And so it's been adapted to that technology. And now the technology is virtual reality, 3-dimensional type technology. The neuropsych part of the DETECT has several different tests. Those include a word learning test. There are a few tests of executive function with shapes and arrows. There is a working memory test involving faces, asking people to remember faces 1 back and then faces that are 2 back. And then there is a memory test, which basically comes back to the words that they were shown initially. So this was the first version of the device that we did a study in people with HIV, where it was all these type of neuropsych testing. And to go over the study that we published a few years ago, I'm not sure if David Loring is on the call, but David is someone in neurology who helped me a great deal with this study, and I'm still very thankful for his involvement. So this is one where we looked at people with HIV. And these were younger people with HIV who were mostly sort of middle-aged, more likely to be African-American. HIV was generally well controlled. About 3/4 were on antiretroviral therapy. And if you look at the bottom of the table, those are some of the neuropsych results. So one of the tests that we compared it against, that we compared the DETECT against, was the HIV dementia scale score. And that's a very brief cognitive screening that people do that really was developed more kind of in the 1980s when we were seeing more people with AIDS. And it's a little bit better for detecting abnormalities in people with advanced disease. And it's been shown to not be as effective in people with more mild disease. The GDS is the Global Deficit Score, which is sort of a composite score of all the domains that were tested. And so an impairment status would be a score of 0.5 or greater. And so most of these people have what we call more minor cognitive impairment. So the device, it's called the NCAD here, correlated very well with our standard neuropsych panel, as you can see here. And it showed that it has the potential for being a much faster way to measure memory than a standard sort of paper and pencil battery that would take a long time to administer. Compared to the HIV dementia scale, when comparing it to a standard neuropsych battery, it did perform better. These are on the left-hand side, a table with the sensitivities and specificities. And so the area under the curve for the DETECT was 0.756, which was statistically significant. And the HIV dementia scale in this population of people who had more mild cognitive impairment just did not perform that well for these people with sort of mild impairment. And once again, thanks again to Dr. David Loring, as well as other folks in neurology who may have helped us out with this study. So since that initial study, the DETECT device has been refined. So there's now a reaction time component to it. There's a target tracking component to it. And there's also this really interesting component that's a non-postural balance test. So as folks know, it's sometimes difficult to measure balance because people actually have to get up and you have to have them walk around. The device has a little component now that is sort of a seesaw tilt test that doesn't require people to get up. And so we're really interested to see how this works compared to sort of more standard balance testing. So between all those things, that's what we have now with the DETECT device. So our current study is an NIH-funded study with 2 different sites here, as well as my colleagues at UCSD, who I've been working with for a long time, looking at DETECT in people age 60 and up. And the goals of the study are to better understand the differences between people with hand and people with AMCI who are HIV negative, to see if there are any things that the device can tell us about these 2 different entities that might be different. We're also planning to look at the ability of the device to differentiate people who have HIV with MCI versus people with HIV who do not meet criteria for MCI. And so this goes back to some of the work that my colleagues at UCSD have done, where they've looked at HIV positive people who then go on to die and go to autopsy. And there is a profile, a neuropsych testing profile that they have found that correlates well with them having Alzheimer's plaques on autopsy. So we're looking at that panel compared to the DETECT. And then lastly, there is a longitudinal component to the study where we're looking to track cognition in people with HIV, as well as your AMCI people who are HIV negative, to see if performance on the device can predict decline over time. Our plan is to enroll 60 people per site, per the 2 geographical sites. So that would be 40 HIV positive and 20 HIV negatives with AMCI. To be in the study, really, we're just looking for people over the age of 60 who meet one of those 2 criteria. We do have some exclusion criteria that are similar to other studies like this, where we're not enrolling people who have comorbidities that might explain their cognitive problems. So things like having a history of stroke, seizure disorder, traumatic brain injury, history of psychoses. If someone has ongoing substance abuse or dependence, we're not enrolling those people. And because there's a really, with the device, people have to have good vision. We're not enrolling people with serious visual and hearing loss. And so previously, we had Dr. William Hugh at the ADRC helping us out with this. And as folks know, he's moved up to the Northeast. So fortunately, Dr. Whitney Wharton has stepped up, and she's going to be helping out with this project. And she'll be sort of our liaison over at the Brain Health Center. And so we appreciate Dr. Wharton for doing that. So what people have is they come in and do the typical neuropsych battery, then they get the detect study, detect testing done. They also have blood draw. We're also doing some hearing tests and audiology evaluation. There's some interesting evidence that people with HIV can have more trouble with hearing. And so we're comparing HIV positives to HIV negatives with MCI on that. And people then get followed for 2 years, total of 2 years, 6 months in between visits. And that's basically it. There's no study drug involved, no other interventions. We're just getting blood and the testing. People do get reimbursed. It's $50 for the screening visit. And then we take it from there. If someone screens in for the visit, then we do a baseline visit and they get $120 for that visit. And like I said, every 6 months they come back in and they get a range in between $50 and $120. So that's all I have to tell you about today with our study on DETECT. We really look forward to getting some referrals from the Alzheimer's Center in terms of people with AMCI. We'll definitely be making some flyers, you guys, and we'll be bringing them by sometime soon. But until then, this is my contact information with my email and my phone number. And this is also the contact information for our coordinator, Rebecca Taylor, who can also be a liaison in terms of getting people into the study. So that's all I have today. I'd be happy to take questions or comments at this point. Should I just go to the chat box?
Well, Dr. Anderson, one question is, what is the acronym HAND?
Okay, so it's an umbrella term. It stands for HIV-associated neurocognitive disorder. So that includes HIV dementia, as well as more minor cognitive impairment. And for this study, we're looking for people on the milder side with HIV, so that we're comparing apples to apples here with people with HIV who have mild cognitive impairment, and then HIV negatives with mild cognitive impairment. Does that make sense?
Yes. And I have posted your contact information in the chat, as well as Rebecca Taylor's contact information. And then just in 30 seconds, like, what is the criteria again to be a part of this study?
So the HIV negatives are the ones that we need help with. We sort of have the HIV, we're based at the Center for AIDS Research, and we have a lot of people with HIV. Certainly, we're happy to take more referrals of people with HIV, but the main population that we need more of is people with HIV, people who are HIV negative, who are over the age of 60, who have AMCI, and who do not have any other reason for memory loss. So that's really it.
Got it. Okay. All right. Well, as soon as we have the flyer, like your one-page flyer, that will be very helpful for us to circulate right now in this digital environment. But you all are um, conducting all of these activities in person, correct?
Sorry, say that again.
You're conducting all of your research activities in person?
We have the ability to do some of the screening remotely. And so we can potentially do that. But if it's someone who's already been diagnosed with AMCI by, say, a provider in the Alzheimer's Center, then we wouldn't necessarily put that person through screening again. So for those people who then go to the visit where they have the detect, yes, the detect has to be in person. We don't have a way of giving the detect remotely at this point.
Got it. Okay. All right. Well, we appreciate you. Thank you so much for being on. We're looking forward to sharing all the great research updates and information with you. We're going to, Matt, come on really quickly, tell us what we can expect with CEP, and then Whit is going to come on for a few minutes and talk about the healthy aging study. Matt. Did we lose you?
Hey, can you guys hear me now? It looks like you guys.
All right, there you go.
Sorry about that. Okay, so today we have, we're joined by Tina Rashid. She is our Tai Chi instructor. We're going to be doing a bit of an extended Tai Chi workout today. So if anyone is interested in getting another workout, it's probably going to be about 30 minutes, but nice and casual. And we're going to be doing that in a few minutes. So please come join us. I'm going to put a link to register for our CEP webinar in chat right now.
Thank you. All right, so Whit, come on in as we have people still hanging out with us. I see 175 people still on. We're going to give them an update about healthy aging. And for those that want to head over to CEP, go right ahead. But for those that want to stick around, hang out with us for 2 or 3 minutes before you go over to CEP. And let's get an update about our healthy aging study.
All right, thanks Cornelia. And let's see here, and we'll share my screen as usual so I can give you a quick walkthrough of what we're looking at. So I'm gonna start off here with some healthy aging stuff. For those that are new to the BrainTalk Live, thanks for joining us today. My name is Whit. I am the communication specialist for the Emory Healthy Aging Study and our Alzheimer's focused sub-study, the Emory Healthy Brain Study. Now, for those that have been with us before, this might be a little repetitive, but for those that are new, I wanted to be able to tell you about a really cool research opportunity that we have, especially now that we are, spending a lot more time doing things virtually. This particular research opportunity is a longitudinal research study that we are conducting, and it is actually done entirely online. We ask our participants to complete an online health history questionnaire once a year. So it takes most participants about 30 minutes to complete it. And during this questionnaire, we're going to ask you things about your general health. Do you have any diseases or chronic medical conditions? Are you taking certain types of medications? But we're also going to ask you things about your lifestyle. We talked about how important exercise is and why we start with exercise every week. We want to know how much exercise are you getting. We want to know things like, are you eating your vegetables and your fruits and your, whole grains and things that are good for your mind and for your body. And we're taking all of this data and we're putting it together to try and better understand not only how we age, but also what causes certain age-related diseases. And then we also use this information to identify potential participants for our Alzheimer's focused sub-study. Now, I do say Alzheimer's focused sub-study. I'll talk a little bit more about some of the requirements for participating in that in just a second. But for the Emory Healthy Brain Study, if you want to participate, these are the requirements that have to be met in order to join. Number 1 is that you need to be at least 18 years or older. Number 2, you need to have something that can connect to the internet. Number 3, you need to be able to read and understand English. And lastly, you need to live in the United States. So those are the 4 requirements that we have. And I pull up our website here to share the screen with you because this is actually how you would go about joining and participating in the study. Our web address up here is the healthyaging.emory.edu. And then you'll see this nice big yellow button up here in the corner that says join the study. So if you were to go through this process, it's a 4-step process where you would register, go through the online consent. We'll get a little bit of contact information from you in case we need to reach out. And then lastly, is going to be that health history questionnaire. And once you complete that health history questionnaire, next year when it's time to update it, we'll actually send you an email and let you know it's time to update it, that information. Now, I mentioned our Alzheimer's study as well, and that's an important one that I wanted to cover today, especially since last week we had one of our participants come online with us and tell us about her experience in participating in the Healthy Brain study. And the thing that I want to stress here is that all of this starts with joining the Emory Healthy Aging study. So if you think about some of the information that we're collecting here, it also doubles as kind of our screening process. And the reason for that is in the Emory Healthy Brain study is we are looking for healthy individuals who do not have a diagnosis of mild cognitive impairment, dementia, or Alzheimer's disease. We also ask some other questions on there about different procedures and health risks on there. We want to make sure that things are very safe for our participants. And which is also why I have my screen shared here, because I wanted to show you this, our YouTube page. We haven't talked a lot about this in the past. We have had, our participants come on and give some testimonials, but we have a lot of content available here. And one of the things that I really wanted to showcase with our YouTube channel is that we've got some really cool videos, just about the studies and the programs. But if you click on our playlists here, we have 2 different playlists. So we actually had a few of our participants agree to do some video testimonials for us to talk about their experiences. And we put those on here for those to view. But we've also got this really cool playlist about the Emory Healthy Brain study. And so on this playlist, we go through all the different types of procedures and tests and things that we're going to be doing during the study visit so that you can get a little bit more information and a little bit more comfortable. And also what this allows us to do is that if you are able to see some information about a procedure and you have questions, we want to make sure that we're very transparent with our participants and that if you have questions or concerns, that you can address them with us directly. So for those, again, that are interested on the Emory Healthy Aging study and potentially the Healthy Brain study, I encourage you to visit our website. You can join the study via our website. And you can also view our frequently asked questions page, the first one being for the aging study and the second page down here being for the brain study. But if you want to talk to me directly, I'm also going to drop my email address directly into the chat. And then I will be able to respond to any emails or questions that you might have.
Okay, thank you, Whit. And if you're still on, we apologize. Not sure why Whit's screen was not transitioning as he was referencing those specific pages. We'll share some of those screenshots with you in a PDF when we send out the PDF of the PowerPoint today, as well as the video recording. We record every session each week. So if you want to relive your the exercise demonstration, or if you want to share with others what Dr. Kandiah shared with us today, that will be available in the coming days. And again, thank you to our first-time viewers, and especially those that return week after week to be a part of our program. Again, head over to CET Live. That is an opportunity to, again, get your heart rate going. If you are not being physically active while we're continuing to practice social distancing, this is a great way to just keep your activity level up. Okay, so I hope you took lots of notes today. I hope this was an informative session for you. We are now about to say goodbye and just look forward to seeing you here next Tuesday. If we know who our panelists are for the coming week, we will try to do our best to get that information out to you early as we can. Sometimes their schedules are changing by the minute, literally. We will have them all set for the week ahead, and then something comes up or they have to bring in a different colleague. So As soon as we are informed about who is a part of the lineup, we will do our best to get that information out to you. In the meantime, thank you again for joining us. There is a post-event survey link that you can click on and give us your feedback. And you still have time to participate in the poll. All right. So grab those links. You have healthyaging.emory.edu. You have a YouTube link. You can email Whit directly. You can also grab the CEP link. You can also go to our website. It's www.alzheimers.emory.edu. And remember, if you want to be part of the Healthy Aging and you're viewing and you're not here in Georgia, you can participate in the Healthy Aging study. So if you're on the fence about research and how you want to launch your research participation, that's a really easy way to be a part of research from the comfort of your home. All right, until next week, we will see you back here at 2 p.m. Eastern Time. Have a great rest of the week, and thanks for joining us.